Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. I'm Rich Duzak from Emory University, and this module is the first part of the series on utilization entitled Recent Trends in Imaging. This module is targeted to Level 5 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to understand the economic and workforce landscape in which radiology services are rendered across the United States, to describe both remote and recent historic changes in the utilization of diagnostic imaging, and to implement practice-level changes aligned with broader societal and macroeconomic trends in healthcare delivery and payment. Here are some additional resources, listed alphabetically by author, for those who would like to learn more about the topics in this module. Over a decade ago, Dr. Don Berwick, who has since served as acting administrator for CMS, and his colleagues coined the phrase, the triple aim. It was their aspirational goal for improving our healthcare system and focused on providing better patient care and an overall better patient experience at the individual patient level, lowering costs while also improving the health of our society at large. It's a grandiose idea and one toward which all policymakers strive, yet Berwick and colleagues realized that it may not be entirely achievable. Indeed, back then, they stated that the components of the triple aim are not independent of each other. Changes pursuing any one goal can affect the other two, sometimes negatively and sometimes positively. This illustration of a triangle, I thus believe, is appropriate, because if you change the length of any side of a triangle, the lengths and relationships of the other two sides by necessity change as well. And therein lies the challenge of executing the triple aim. The unintended consequences of any one action on the other elements of this tripartite goal. "It's the economy, stupid," was a phrase often cited by James Carville when he served as a campaign advisor to Bill Clinton in his successful 1992 presidential campaign against then-sitting President George H.W. Bush. It really says it all about a lot of what goes on in Washington, where most everything comes down to money. And it is healthcare's impact on the economy that has truly fueled much of the ongoing policy debate in our country. It would be great to provide every imaginable service to every person, but that's just not economically possible or sustainable. Right now, we are on a trajectory for healthcare to exceed 25% of the gross domestic product in just a few years. When that happens, 25 cents of every dollar spent in this country will go to healthcare. Dollars that otherwise would go to education, infrastructure, or a variety of other important services. Every additional dollar spent on healthcare, by necessity, means trade-offs in one way, shape, or form. As part of that conversation, medical imaging has gotten a lot of attention. In a review article in the New England Journal of Medicine back in 2009, John Eigelhart highlighted the relative costs of medical imaging in this country. Of note, he pointed out that we have far more MRI units and other expensive imaging devices as well than any other industrialized country. And that ready availability of imaging equipment likely fueled the seemingly unfettered growth in medical imaging across the country that we saw in the early 2000s. This is a graph from that article of the cumulative change in a variety of medical services between 2000 and 2007. You can see here how medical imaging has been at the top. Healthcare policy's bleeding edge, it so seems. Given the dramatic growth in healthcare expenditures across the country, that put our specialty, radiology, dead center in the crosshairs of policymakers. Remember, policymakers have to decide how finite dollars are spent. And at the 30,000-foot level, there are only three ways to cut spending on healthcare. You either reduce costs, or reduce volume, or you do both. In prior modules, we have talked a lot about the ways that per unit cost reductions have been implemented over the last decade in medical imaging. Those changes in the RBRVS system leading to a very different and overall lower Medicare physician fee schedule amount. And how CPT codes have been bundled and edits applied, all with the goal of reducing per scan or per examination unit costs. Those many changes are illustrated in this figure created by the American College of Radiology, which highlights the relative magnitude of a variety of these uncoordinated and rapid sequence policy interventions that began around the time of medical imaging's peak, as I've illustrated in Eigelhart's article. In the next module, we will focus more on how policymakers are working to control volume. We have already talked about some pretty weak initiatives intended to curb financially driven self-referral, but we'll go into a lot more details about emerging computerized physician order entry and decision support tools, as well as the hugely profitable radiology benefits management industry that has been fueled by insurance companies' zeal to save money. It is important to note that while everybody continues to talk about reducing spending on medical imaging, that they continue to rely on that very age data by Eigelhart. Our team's more recent analysis that you see here, like analyses from other groups, has shown that that trend has now dramatically reversed. Relative change in spending on imaging and non-imaging services over time is plotted here, with the zero line in gray. You can see clearly that annual changes in imaging were above that gray line in those earlier years pointed out by Eigelhart, meaning that spending back then each year continued to grow. But those curves reversed in 2007, and spending in subsequent years on imaging was in successive decline each and every year thereafter. Contrast that to the yellow gold line for non-imaging, which continues to be above the zero baseline for annual growth, meaning that unlike imaging spending, which has declined, spending on non-imaging services continues to increase every year. Those sequential reductions each year led to dramatic reduction in the utilization of medical imaging all across the country. Here's an illustration showing Medicare Part B imaging spending from the Neiman Almanac from the Neiman Health Policy Institute. Spending on imaging indeed rose up until 2007 when it peaked, but it has been in decline ever since. That said, take a look at the most recent year changes. That decline is now flattening. And, as I'll talk about shortly, that may be a marker that because of a growing and aging population, we're going to be back on the rise again soon. Here's a graph of the United States population over time. Our country's population continues to grow, and that means that we have more and more people who will need healthcare services. And imaging is increasingly a healthcare service relied upon by many. We are already seeing that in some areas, imaging is continuing to buck the national trends. As patients have trouble getting primary care and specialty care access, they are continuing to turn to emergency departments and get their imaging there. Imaging thus may be the proverbial canary in the coal mine, a harbinger that utilization may soon rise in other sites as well. Looking at the drivers of that increased emergency department utilization, I think, is illustrative, because it highlights trends that you may see in your own practices that could help you predict what will happen to utilization in your own communities. Nationwide, in this currently unpublished data from the Neiman Institute, we have found that on a per capita basis, emergency department encounters are increasing all across the country, at least in the Medicare population. That means that not only is the population growing, but on average, individuals in that population are individually using emergency department services more frequently. And so it's a bit of a double whammy. But it's a triple whammy as well. Of note, the complexity of those encounters is increasing as well. So a growing population that on a per capita basis is using the emergency department more frequently is also showing up in the emergency department with more complicated presentations and workups. The lower level complexity encounters, those in gold and gray and green as you see here, are declining, while the fourth level complexity encounters in blue are remaining about the same. All the while, the fifth, that means the highest level complexity encounters, those rendered by emergency department physicians on their sickest patients, are increasing dramatically, the bar graph in red. I think that illustrates what's going on in our country as a whole. As our population grows and patients age, their presentations become much more complex. We showed in this paper back in 2012 that those more clinically complex patients, to no surprise to any of us as radiologists, undergo more imaging. In fact, the patients who emergency department physicians contemporaneously scored as their sickest patients underwent about 6 times as much imaging as those they scored as less complex. When you think about changing utilization then, I would encourage you to think about not just volumes, but also patient complexity. Here's a table from an article from the Neiman Health Policy Institute group, led by Dr. Andy Rosenkrantz at NYU, studying the Medicare scored complexity of patients seen by a variety of specialty groups in 2015. You see quite clearly here where interventional radiology, nuclear medicine, and diagnostic radiology stand. Of the over 50 specialty groups we were able to uniquely identify using Medicare claims, interventional radiology, nuclear medicine, and diagnostic radiology ranked 4th, 16th, and 21st in terms of the complexity of patients they served. The bottom line, as radiologists on the whole, we provide services to pretty sick and complex patients, and more so than many other specialties. But like all data, this is not a one-size-fits-all proposition. There's a lot of geographic variation in that complexity, with some regions of the country seeing overall healthier and some much sicker patients. And by radiology subspecialty, that complexity varies quite a bit, with interventional radiologists in gold here seeing on average the most complex patients, and breast imagers in pink here seeing the least complex ones. General radiologists as a group are somewhere in the middle, as you see them in salmon color on the left. My point in all of this is that simple counts in the numbers of studies interpreted doesn't tell the whole story of utilization in radiologist work. Again, volumes according to Medicare are down, as you see on the bottom right. But most of us in our practices, when we think about our work lists, have the perception that we're a lot busier than ever before. And I believe we are. So how do we explain that apparent disconnect? It all gets back to patient complexity, I believe. Take this CT scan to rule out appendicitis, for example. It's a normal study in an 18-year-old and a pretty straightforward examination to interpret. Contrast that to this study in a 65-year-old to also rule out appendicitis, who was found to have an appendiceal carcinoma, in whom additional images demonstrated peritoneal metastases. As you can imagine, that interpretation was a far more complicated and time-consuming one. Yet, both studies get billed using the same CPT code and within individual payer fee schedules get paid the same. That's because the RBRVS system considers the work involved in a typical patient and pays us in a one-size-fits-all manner. I would submit to you, though, that patients today are increasingly complex, and that's where the myopic focus of many on counting RVUs that we talked about back in Level 4 is failing us. Why is that? First, the population in the United States, and for that matter, the entire world, is aging. As a general rule, you will find more disease as well as more incidental findings that need reporting in older patients. Second, the utilization of imaging has become much more judicious in recent years as the Choosing Wisely campaign continues to take root, as utilization management tools are increasingly embedded into clinical workflows, and as physicians become much more conscientious of healthcare resources. As a result, many studies that were nearly universally negative ones when I started practice some 25 years ago are no longer even performed. So, we're all seeing more studies with more positive findings, and that means an overall increase in service complexity. You've heard me now over the course of many modules telling you that per unit payments for imaging services have been historically declining. That alone would mean we're doing the same for less. But as we now dig a bit deeper into this, we see that service complexity is also increasing. What I think that means is that we're actually all being asked to do more for less. That takes us back to Level 2 and Level 4 modules on why we all need to work smarter. Adopting reading room coordinators and non-physician providers, for example, as we've talked about several times. And increasingly being open to artificial intelligence to allow us to work more efficiently. Again, it's thinking outside of the box. If all you're focusing on is your day-to-day work list, you will miss this all, and be strategically disadvantaged compared with your colleagues who are looking at their practices and the healthcare ecosystem even more broadly in a much more holistic way. But those innovations that we've talked about before require a good bit of planning, coordination, and infrastructure to support. And as such, they aren't always easily implemented and executed within small radiology groups. I believe that this is one of the many market changes that is fueling the increasing trend toward practice consolidation, wherein radiology groups are merging, or smaller groups are being assumed by larger ones in order to take advantage of economies of scale on many fronts. It is the changing healthcare ecosystem, along with changing utilization of imaging services, as well as expectations about how those services should be rendered, that together are all drivers of this integration phenomenon. In some environments, when two hospitals merge, the new parent organization demands the consolidation of two former independent practices so as to provide consistent and standardized services across the new healthcare system. In other settings, there are geographic mismatches, workload balances, and/or administrative or financial issues that drive such integration. Let's talk briefly about a number of these, because together they all impact how your practice will handle changing imaging utilization. One health policy imperative that we've talked about several times now is an increasing emphasis on patient access. Americans in more populated areas have an easier time finding a hospital or imaging center staffed by an on-site or local radiologist to provide their services. You see all counties outlined in this U.S. map here. The blue counties are ones where there is at least one local subspecialist, and the green ones are those where there is at least one generalist. You'll also see a lot of counties colored white, meaning there are no local radiologists based there. In order to provide services to patients in many of these areas, radiology groups are increasingly entering into teleradiology or other remote staffing scenarios. Obviously, bigger groups are better equipped to handle those manpower and coverage challenges than their smaller counterparts. And although there is a huge push towards subspecialization by many of our training programs and certainly the American Board of Radiology, it is worth noting that the majority of radiologists in this country still practice as generalists, meaning that less than half of their time is devoted to a single subspecialty area. That is more frequent among non-academic radiologists, which is not surprising, as well as among older radiologists. Striking the right balance of subspecialist versus generalist coverage in order to meet both volumes and complexity is indeed a challenge, and again, something easier to do in larger practices than in many smaller ones. But the biggest drivers for consolidation, I believe, are financial and administrative. We have talked about a number of things on this list throughout Replete, and you now know how complicated this all is. The many items on this list require a considerable amount of expertise and work as well, things that aren't typically available in smaller groups. So again, it's not just changing examination volumes and changing service complexity driving these market changes. It's this host of many things related to the business of radiology that we have talked about throughout Replete. Perhaps the most compelling of these is new payment systems. You now know that under MACRA, and specifically MIPS, which is the way most radiologists will participate in MACRA, the differential payments to physicians under Medicare may soon vary by as much as 20%. And being a winner rather than a loser will require a lot of systems thinking and systems reorganization. Again, things that smaller groups will often struggle to expertly and efficiently address. That's why CMS, way back when it implemented MACRA, predicted differential performance under MIPS based upon your group size. In particular, they've predicted that physicians in the smallest of practices will be 87% likely to get penalties, whereas physicians in the largest of practices will be 81% likely to get bonuses. You will indeed need to keep this in mind as you think about the right size and structure for your practice over your career. And understand that the very features that will allow larger groups to perform better in coding and billing under current fee-for-service systems are the same ones that will allow them to perform better under emerging value-based payment systems, as well as handling the changing volume and complexity of radiology services in the most nimble way possible. With that in mind, I'll paraphrase Charles Darwin. It is not the strongest of physicians that thrives, nor the most intelligent, but the one most responsive to change. Adapting to change and aligning incentives are indeed themes that I've stressed throughout Replete. because those are principles that will determine your practice's success in the future. In the next module, we will talk about some approaches used by payers and practices alike to attempt to optimize appropriateness and manage utilization. Again, more change to which you will need to adapt. In summary then for this module, after a long period of growth, the utilization of medical imaging in the United States began to decline around 2007, but that decline now seems to be slowing. With utilization continuing to rise in some settings, our growing and aging population portends continued and broader growth, along with an increase in service complexity. As a result, radiology practices and the healthcare system more broadly will need to adapt to our changing world in order to meet the increasing and often competing needs of our growing and aging society. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.